So most of you probably haven't heard of the term pain languages, and it's really something that's new and novel to my clinical practice and my research that we were doing and generating with my research team here at Azusa Pacific. It's something that was really born out of a need, born out of a finding in clinic that patients were telling us certain things and they were trying to express things through the language of pain, but we really weren't understanding and having an idea of how this influenced and impacted us in the clinical setting. So we said, there's got to be a different way. It's got to be a different way of looking at things. So we set out to explore what these different ways of communicating with somebody in pain, especially our patients with chronic pain, and realizing that maybe the things that they were telling us through the limited language of saying, I have pain, was really an expression of other things that were going on in their lives. And if we can get a grasp of the things that they were trying to tell us about the other things in their lives, then we can have a better understanding of how we needed to treat the patient and how we needed to address the problems and create an environment that they can heal and get better and recover. So really our journey started with the realization that acute pain and chronic pain are really different animals. For such a long time, and even into the last 5 or 10 years, I was teaching that chronic pain and acute pain were pretty similar animals. They were based off the same concepts, and the only thing separating the two was more of a temporal factor. So if someone was sitting there at 2 months and 20 days, and they were considered acute to subacute. But as soon as they crossed that threshold into 3 months, then they became chronic. The thought within the process was that really acute pain and chronic pain had the same physiological mechanisms, the same drivers, and everything about the two were the same. And so that kind of dictated and led us to our treatment paradigms, where we treated acute pain and chronic pain identical. Chronic pain was treated just like you would acute pain. It's just someone who had pain for a longer period of time. And we found that that didn't work. People with chronic pain were not getting better, and sometimes they were actually getting worse when we used the acute pain management paradigms. So as we start to explore and research has grown and evolved and gotten bigger, and our understanding and depth of knowledge of the pain sciences has grown, we've begun to realize that acute pain and chronic pain are really different animals, just like cats and dogs are different animals. If we look at acute pain on the left, you'll see that a lot of acute pain is really founded on this notion that the biological factors drive a lot of the pain. And I would say that that is fairly consistent, and that holds fairly true, that if you're looking at someone who has just recently injured something, there's a huge component of biological pain, like biological aspects, biological and neurophysiological mechanisms driving someone's pain. But when you start to get to people who've had pain for 3 months, 6 months, 3 years, 6 years, then you have to start to question and think, do these people have the same biological drivers that someone with acute pain had? I would think that people would heal in 6 to 8 weeks. That's what we learn in school. And it never really makes sense that it would last for 6 years. You would think over the course of 6 years that someone's injured tissue would heal up. And so now we're realizing that is really truly the case. Biological factors play a smaller role in people with chronic pain, whereas things like psychological and social factors play a larger role. And I don't think this is new to anybody who's probably here learning more about chronic pain and learning more about pain mechanisms and learning more at a pain summit. I would think that that's a fairly common view, that there's a biological, psychological, and social component to pain, and that psychological and social components are larger drivers of someone's pain than in acute pain. I would think that most of us would say that our subjective needs to be different for someone who has chronic pain as opposed to someone who has acute pain. But the challenge that we have as physical therapists is really how do we generate a subjective examination for someone with chronic pain? Because for most of us in our training, we have one of these factors that's involved. One, we don't like to ask about some of these things, these psychosocial issues, because one, we don't understand that there is a difference. Some of us don't feel that it's a part of our practice. Sometimes we don't know what to do once we find that information. So why ask that information if we don't know what to do about it? Sometimes it goes to our own internal comfort with things. We don't feel comfortable asking about the questions in terms of someone's psychological background or someone's social fit background and what might be driving things. So a lot of times we're not taught how to do it in school or in clinical practice or in the mentoring we get. And to be honest with you, oftentimes it's very hard to teach how to look for these psychological and social factors that may be driving someone's problem. So we set out to see if there's a different classification system that we can start to utilize when we're in the heat of the moment with our patients to help us understand how we need to start to treat our patients and how we need to start to move them forward. And really we started as we start this journey of looking to say, is there a classification system that we can start to look at that is clinically based that we can use from day one in our subjective with somebody? We started with the question is, what is the purpose of pain? And if we really start to get to the nuts and bolts of things, the purpose of pain is protection. And in chronic pain, when we're asking patients who have chronic pain, our question should not really be about what tissue is damaged, because if someone comes into me with 3 years history of pain, my thought process shouldn't be what tissue has been damaged for 3 years, but instead it should be what am I trying to protect for the past 3 years, or what feels threatened, or what is being threatened for the past 3 years, so that I am starting to warn the body that something is going amiss. So pain language is really trying to dive into say, what is my patient really trying to tell me? What are they trying to tell me about protection? What are they feeling threatened by? So pain language is based, once again, on this concept that pain is more than the biology that's associated with it. We're trying to provide a categorization that allows clinicians to understand some of the non-biological factors that may be driving our patient's pain. If we begin to know what a patient's pain language is, it'll give us insight to what our patient needs from us in order to get better. And so just quickly, you can look at that diagram of the right, and these are some of the pain languages that we're taking a look at, things like fear and sadness and shame and abandonment and anger and disgust, or lack of control or loss of control. So when our patients really are starting to talk about pain, our thought process in the back of our head should be, they're talking about pain, but are they really telling me fear? They're talking to me about pain, but are they really telling me sadness? They're talking about pain, or are they really telling me about shame? And it goes on into abandonment, anger, disgust, or loss of control. So how are these pain languages really developed? Well, it began in clinic, from talking to patients, having 20 years of experiencing working with patients, and saying, oh, is there a common pattern that we're starting to see? From what we saw in clinic, we start to progress and explore literature to see if there's actually literature based around pain languages or something common. And we found that there's nothing about pain languages, but there's a huge amount about emotions and pain. And so we said, well, emotions and pain, they're fairly similar. And there's even argument in a line of literature and line of research and a line of thread of thought that says pain is really a form of an emotional learning. They're so closely tied in the way they interact that maybe pain is a type of emotion or maybe just a close cousin. So with that in mind, it freed us to start to take a look at, is there psychological literature and concepts revolved around pain languages that really, when pain is being told to us, it really expressing some type of emotions. Now, is there evidence to suggest that pain and these emotions are really linked together? Increasingly, there is a huge amount of literature being involved and evolving and being generated that looks at emotions and its link to pain. If we use fear as an example, and we use fear because it's probably the most common studied emotion as it links to chronic pain and pain itself, we find actually multiple researchers looking at this, and there's been a significant amount of literature being generated. And Mulders is doing a huge amount of work on it, and Rogelio Coronado is doing a huge amount, and Kristen Archer. All three of their labs are generating just a huge amount of literature. It seems like almost monthly that links fear to pain. So you can see that the literature is catching up to some of these thought processes. So what other basic emotions are there? Really, if you look at it, this is very similar. You'll see a great similarity between our pain languages. You'll see that there's 8 basic emotions, although this will vary from person to person and from researcher to researcher. The most common number of basic emotions are between 6 and like 10. But in general, we used 8 because this is one of the ones that are probably more commonly accepted in terms of the basic emotions. So we look at anger, and anger has a purpose just like pain has a purpose. Anger has a purpose, and its purpose is to fight against problems. If we look at anticipation, it's looking forward and planning. If we're looking at joy, it's to remind us of what's important. If we look at trust, it's to connect with people who help. If we look to start looking at the negative components of emotion, we start to look at things like fear, and fear is to protect us from danger. Surprise is to focus and protect us in cases of new situations. Sadness is to connect us with those we love. And disgust is to reject what is unhealthy for us. So if we start to look at these basic emotions and start to put it in a framework for which we start to look at our patients, we start to see how these basic emotions are translated into our pain languages. Things like fear and sadness and shame and abandonment and anger and disgust and loss of control really have their foundations and their origins in these basic emotions that you'll see to the left. If you start to work with our patients with chronic pain or persistent pain, you start to ask them the question. You just start to ask them the story about their life and how things came about. You'll start to see commonalities. And if you listen deeply enough, you'll start to pick up these underwriting themes that exist. So there'll be themes where their pain is really related to fear. There are themes where their pain is really related to sadness. The pain is really related to a sense of loss of control or abandonment or shame. And so when we're listening to our patients with these different problems, in the back of our head we should be really thinking, they're telling me they have this pain, but in their story, what am I picking up? Am I picking up that they're really saying fear? Am I picking up they're really saying anger? And realize that these are the general class categories, but also there can be overlap, or there could be multiple of these categories existing in our person. And you say, well, that's interesting, but why is that important for me from a clinical perspective? Well, this helps us. If we understand what they're trying to say to us, then we can really understand how we need to help them forward. For instance, if someone says that they're having pain and you're picking up that their pain language is really fear, then in all our treatments and in all our interactions with them, we need to be focused on providing them safety. Whether it be their exercises they're doing, whether it be their manual techniques you're doing, or whether it be their education you're giving them, it all should be focusing on reducing the fear by giving them a sense of safety. If someone's really saying that they're sad, then you should be providing an environment and a context that provides joy and happiness. If someone is feeling a sense of shame when they're talking about pain, say they've been abused, say they've been traumatized, And really, when they talk about pain and they're talking about their pelvic pain, there's really a shame that's underlying that. Then as you start to work with them, you need to focus on developing a sense of pride and developing their contexts in which they work, when they're doing exercises, when they're taking control of their life again, building in pride to that person. If someone has abandonment, then you're developing a sense of safety and security. If someone's angry, you're trying to give them peace and create a sense of peace within them. If someone's disgust, then you're trying to provide an environment, an atmosphere in which delight is a main component of that interaction that you have with them. And if someone really feels that there's a loss of control, that the pain is taken over and they have no control over their life anymore, then really your job as a therapist is to use the things you do, but in the context of giving that patient a control over their life again. Your communications, your interactions should be based upon creating those environments for them. So the clinical implications of all this information? Well, increasingly evidence is demonstrating that pain exists at the intersection of the body, the mind, and the soul. Appropriate management requires an approach that combines all these elements, not just the biological body, not just the psychological, but also the social components of people as well. If we can begin to classify and subgroup our patients, this allows more for efficient and more standardized treatments. And it allows us to be able to identify a patient's pain language, allows for us to more quickly classify them into silos or chutes that we need to start to incorporate as we interact with someone from a psychological and social aspect. Once we classify it, it allows us as clinicians to begin the process of integrating these psychological components with the biology and of what we're trying to work on as well. So how do we as a research team start to attack this? How do we start to approach this? You know, it started with a clinical question. I'm a clinical researcher, and I still have my foot in clinic. And so we come up with this concept. We feel that it's going to be a nice concept for teaching and being able to be utilized as we start to train our clinicians and young students on how to interact with people. So we started with exploring the role of pain and emotions, looking at the literature, looking at clinical practice and seeing if there's a link. And we've found pretty much that there's a link. Based off of that connection, we said, is there a way that we can start to categorize that? And that's the pain languages. So we came up with the pain languages as a means of categorizing. And that's where we're at right now. We've developed the pain language as a categorization system. So in the future, our lab is taking a look at creating questionnaires and means to determine someone's pain language in a more objective manner. And then to conduct trials to determine if these pain languages change in results in terms of how patients progress, but also whether there's reliability and consistency in someone's ability to identify the different pain languages. And then to begin to explore linking these with different interventions. So taking a pain language and saying, if you really need to build safety, how do we do that? Is there certain interventions that will be the most effective in helping us to generate that environment of safety for patients? So you can see that we have a way to go in our clinical research, but this is where we're at right now. We're still at the beginnings and we're still exploring, and it's likely to morph and change as we move forward. But we do feel that there's a need for this in the profession, and we're really, really excited about where this is taking us. And so we're thankful that we had the opportunity to share this information with you today and take a quick look at the pain languages. And we would love to hear your thoughts. I mean, we love doing these type of talks and we love doing these type of presentations because it gives us a chance to pick your brains. This is really a community of people who are looking to find answers for our patients and solutions that our clinicians can give to people. So with that, we'll end our talk on the pain languages. So thanks for listening in, and we look forward to the conversations to happen afterwards. Thanks, everybody.